Hi, everyone. Thanks for being here. My name is Dr. Luis Abrantes. I'm a general dentist bound out of Birmingham, Alabama. So one suburbs of Birmingham, Alabama. The actual city is Mountain Brook, but I think most people are familiar with Birmingham, I guess. When you talk about Alabama, not a lot of people come here on this. You have to. And tonight we're just gonna be talking about composites and maybe some protocols and some some of the things that I do in my practice that help me out, and some of the things that I don't do. And hopefully, after this lecture today, you'll take something home that you can apply tomorrow when you go back to work. And it's just a 1 hour lecture. There's not a lot you can fit into 1 hour lecture. Most of these things are probably just going to be a refresher for you. Hopefully, there will be some new things. I'll talk about some new products around the market, but I mainly want to focus on a summary. I cannot go really in depth into some certain things because of timing, but I will uh, try to touch on the areas that are more important. And after this lecture today, you will understand a lot better some of the newer composites, including the universal systems. We're going to be talking about the C factor and why it's important. And also, we're going to be talking about some techniques to improve your aesthetics, maybe the handling of the composites and what you do at work. And for those of you who are wondering why I have an accent, yes, I do. I'm originally from Cuba. I'm Cuban, and I'm from a city in the center of the island. It's called Ciego de Avila, and been in the States for several years now and practicing for 2.5 years now. And going back to our lecture is going to be divided into a topics. I'm going to start with some little bit of history and I'll go all the way to clinical cases. And in the middle, we're going to be talking about all the other stuff like C factors and some of the elements that I was mentioning today. And at the end of the lecture, I'm going to have at least 10, 15 minutes where we can ask questions. Maybe we can interact. You can type your questions in the chat box and I'll read them and answer them at the end. I'm going to then continue to the lecture. That way I don't take away too much of your time. And I'll start briefly and with a little bit of history of composites. Composites, we've been using composites around maybe almost 60, 70 years ago. 1950s were the original, I guess, composites, if you want to call them. And they were based out of silica cement and acrylic resins. And basically, what happened was with these early composites, they were very, very soluble. So they pretty much after a couple years, maybe 4 or 5 years, whereas the lifespan of these composites, they pretty much disappear from the mouth. I mean, the own saliva of the patients would wash away these composites. So this led to a research to see how we could make composites a lot better and to take it to the levels that we're doing composites nowadays. And it wasn't until the mid 1950s where Dr. Michael Buonocore, I don't know if I pronounced it right, invented, well, I don't want to say invented, I guess, put the hydrofluoric acid, the phosphoric acid into the system that we have today. And the phosphoric acid is what we use for the etching. And this is basically what the phosphoric acid did. It laid the groundwork for how we do bonding today. We cannot do proper bonding without phosphoric acid today in enamel and dentin. The early commercial composites started in the 1960s and 1970s, and this is when we started introducing the bis-GMA monomer. The bis-GMA monomer, I'll talk about that a little bit more in the next couple of slides, but it's pretty much what it is present in almost every composite we use, if not every composite we use nowadays. And it basically works as the matrix for all the other parts that are the components of a composite. The original composites were called microfield. We don't even use microfields anymore, and they were made out of quartz and glass particles, and that's when we introduced that term that we call the white filling. And basically, these were less soluble than the original composites. They lasted a little bit longer, But the big problem we had with the microfields composites is they were very hard to polish. It was way too bumpy in the surface, and this led to higher failure rates and more plaque accumulation and a lot of other stuff that happening. So basically, after several years of evolution in the composites, in the 70s was when we had the microfield. They started being a lot better in terms of polishing. The hybrid composite came down in the 90s, a lot better, because they started mixing some of these composites and make that in a hybrid mode where it was a lot easier to polish, and you could put them in the posterior region. The original composites, by the way, were only in the anteriors, because if you put it on the posteriors, they would break. And then the nanofield came into place, followed by the bulk fields that we still use nowadays. I use bulk fields occasionally, depending on the type of restorations that I do. And the nano hybrids and the universal systems, which is what we're going to be talking about today. This came out in the late 2000s, 2010s, and 2020s. And the one that I'm going to be talking about today came out very recently, just about a year, something ago. So if you want to divide composites into four major groups, we want to say microfields we don't use anymore, and then we have microfields and nanofields, which is what we use today, and the hybrid composites that contain sometimes a little bit of ceramic portions, and then we don't use that in direct restorations too much, but we use it in other areas. So what are the key ingredients that we find in modern composites? The first thing that we're going to be talking about in modern composites is the matrix, which is the BSGMA. The BSGMA is just the resin that allows the other parts of the composite to be dissolved in. This is what we call the backbone monomer of the composites, and this is what determines the handling, the shrinkage stress, and the flexibility of the composite. The other key ingredient we have in composites are the fillers. And fillers, there are several types of fillers. We have the glass, the silica, zirconia fillers, and organic materials. There's a lot of things that are part of the composites, and depending whether you have a microfill, nanofill, depending on the type of composite you have, is the type of filler that you will have. And fillers basically determines the polishability of the composite, amongst other things like the wear resistance and all that. But the most important thing that we need to understand about fillers is the smaller the filler, the easier it is for that composite to be polished, and the easier and the shinier it will become, the better the composite will look. Other things we have in composites, especially direct restorations composites that we place in the office, is the photo initiators. And the most common photo initiator we have is the photoquinone systems. And it's basically, in other words, is the one responsible for when you shine a light on the composite turns hard. That's basically what it does. Now, let's talk about other let's talk about what's important in a composite, and let's talk about a little bit of protocol. We cannot talk about composites without talking about C factor. C factor is one of the things that in dental school, they really drill into your head. C factor. Maybe you hear about it in seminars, you hear about C factor here and there, and you say, oh yeah, I understand it. But the minute you get to work again, you forget about it, you start doing things however it's faster. And it took me at least a little time to understand it and to really do some research, and maybe go to a facility like Bisco and look at it under a microscope and seeing how detrimental it could be for a restoration if you don't follow proper protocols. And let's talk about, when we talk about composites, the average lifespan of a composite in America, I mean, with the ADA, the American Dental Association, says that it's about 5 to 7 years. I hate that term, because I don't want my composites to last 5 to 7 years. I want my composites to be in the mouth for 10, 15, 20 years plus. So it is our job as clinicians to move that needle towards the higher end of the spectrum. We don't want to be the average. We don't want our composites to last 7 years. We want our composites to last 14, 20 years. And the only way our composites are going to last longer than the average is if we do proper protocols, and if we understand what makes composites fail. And C factor is actually the major factor for failure of the composites. And what is C factor? Many of I'm sure all of you know it, but let's just refresh what C factor is. It's basically the ratio of bonded surfaces to unbonded surfaces. This influences the marginal integrity of the composites, and the higher a C factor is, the higher is the shrinkage, the more that composite will separate from the wall of the restoration that you're bonding that. We can find the highest ratio of C factor in restorations that have many walls, like a class 1. For example, a class 1 restoration has a C factor of 5. And ideally, we want to be 1 and below. That's an ideal C factor. What happens with a high C factor? When we have a high C factor, basically we create high stress. So let's break it down here. We have a class 1 preparation. We have 1, 2, 3, 4. And if you want to count the floor of the preparation, that will be the 5th wall. And then you have the top of the restoration, that will be the 6th wall. So if you think of it like a cube, you have 6 sides. And in this particular case, if you bond the restoration in this case, you will have 5 bonded surfaces over 1 unbonded surface, which is the top of the occlusal part of the restoration. If you divide the 5 bonded by 1 unbonded surface, that will give you a C factor of 5, which is the greatest stress you could have in a restoration. If you have a restoration like this one, and you bulk fill that restoration all the way to the top, you will 100% cause breakage on the margins of the restoration. That restoration will separate from the tooth, and eventually this restoration will fail quicker. You will be into the 5 to 7 year margin that we were talking about the American Dental Association. You probably will be below the average. You will not be above the average. So we want to be clinicians where we want to be above the average. We don't want to be in that scenario. And when we bulk fill restoration, like a class 1 restoration, so you can understand what happens is this wall will pull towards the center, the bottom wall will pull towards the top, this wall will pull towards the center, and the top wall will pull towards the center. Basically, what happens is everything pulls towards the center. And when that happens, you create a lot of stress on this cusp over here. You could even bend cusp of the teeth. If they're skinny enough, those cusp of the teeth will bend in such a way that even class 5 lesions could form in this area. And it could be very detrimental to a tooth. It could cause an array of other problems that you don't want in your restoration. So let's talk about C factor. Is the lowest the number is the better. It will be the better for us. And it's basically, C factor is another way to put C factor is the polymerization shrinkage of the restoration. All composites, regardless of whichever composite you buy in the market, will have an average shrinkage of about 1 to 6%. If you're lucky, you can get it closer to 1%. But you may think 1 to 6% is a low number, and that's actually a very, very big number, because it could cause problems that if you add that 6% in all the walls, this percentage increases dramatically. And this stress is basically developed when you cure the composite and it turns into the more pasty type of liquid form to the hard form. All those molecules organize in such a way that it makes the composites become smaller. And this is what causes debonding, postoperative sensitivity, and it causes all the things that you get the patient coming, hey, my composite is sensitive. Ever since you touched that tooth, my tooth has been sensitive. All of these problems that you don't want to have probably could be eliminated if you follow protocol properly. So what are some of the strategies we use to minimize the shrinkage stress, to put that C factor below 1? Basically, use the use of flowable liners. I always use a flowable composite liner in all my preparations for composite. This allows for a flowable liner will be about 1 millimeter on the floor of the preparation, basically just barely the floor of the preparation. The goal of this is to act as a stress absorbing layer and to improve the adaptation to the margin. This will be the number one thing you will do to minimize the shrinkage stress of the composite preparation. The next thing you're gonna do is place those layers of composite in a slanted way, almost like a triangle. In that way, you will have, for instance, in this particular case, you only have one and two bonded surfaces over one unbonded surface. So the ratio here will be about 1 or 2, depending on how many you have here bonded to this restoration. This allows for the walls of the composite to pull in such a way that they don't debond from the surfaces of the tooth. The next layer of the composite will be placed somehow like this, and if you can follow the logic here, you can keep gradually increasing those layers in such a way that you don't create gaps due to the shrinkage of the composite. One thing that is very good that I forgot to mention here, make sure that you check your curing light, and it's got what we call post curing. What does that mean? That your curing light starts low and it slowly starts increasing in intensity. Those curing lights that you shine on the tooth and all of a sudden gives you the full intensity, those are not very good curing lights. The curing light does matter. Not all curing lights are the same. Not because it has a 100 and the number of the watts and all that is good. You need to make sure that the curing light has what we call a pulse curing, that starts with a low intensity and then gradually increase to higher intensity. And of course, use materials, composites that have a lower shrinkage formulations, and build the tooth in a way that is anatomically built up, and with each increment built in a slanted way. So let's talk about, and everything has to do with C factor here, but let's talk about marginal integrity of the composites. What happens when you don't bond the composite properly? I remember by the way, this is my first restoration that I did ever. This was, I guess, maybe 2019, 2018, I can't remember right now. This was my very first composite. When I did the preparation, I thought I was killing it. I was very happy. I put my rubber down. I not have a gap here and all that. So understand, this is done by a third-year student. This is my very, very, very first composite. Don't judge this one. But I want to show you what happened on this composite. I finished my composite and I was like, oh my gosh, this is good. I killed it. This is a great composite. Not knowing what was happening, I take it to my instructor. He says, yeah, I mean, okay, composite, but I'm still gonna give you a 3 out of 4 because of the bonding you have from the surface. And what are you talking about? I said, take a picture. So I went ahead and take a picture. That's when I got hooked in cameras as well. I took a picture of the composites and all that. And then I saw this white line right here. And I saw that white line right there. And then that's when it clicked. I was, oh, okay. So this is what the C factor, this is what the shrinkage mean. So that line right there, basically what that's telling you is when I cured that composite, I did not place the lines properly enough, and that composite started debonding, pulling that enamel and keep creating little gaps right there. Even if you polish, even if you spend your whole morning here trying to polish that composite right there, these right here will be micro leakage. This will cause micro leakage over time. So I don't know if that tells you anything, but if you have a camera in your office, start taking pictures of composites. And once you finish, look at those composites, and you'll see a lot of errors. I have learned a lot from my own mistakes. I have learned a lot from my own pictures, and this is one of them. My first composite, and I kept the picture and I show it every time I do a lecture. I show that picture because it reminds me and it helped me understand what shrinkage was at the moment. And marginal integrity, basically what we call the white line. The white line is actually a term that you will see in many literature and some places of research and all that. They talk about the white line interface, which is basically that area where the composite separates from the tooth. So it is an actual term. This is somebody else. Composite is not mine. And basically what happens at the white line, if you put it under a microscope, this is what you see at the white line. My enamel cracks, so basically the enamel fracture at that area, and the next thing that happens at the white line is that separation. That separation, that's usually what causes the staining and all the things that when you see the composite after 3, 4 years start staining. If your composite stain after 3 years, I don't care if the patient drinks wine, coffee, whatever they drink. I have composite stain in the mouth. They don't. If you do it properly, they will not stain so easily. At least not in 3 years, unless the patient is clearly not taking care of their mouth. But if you polish, if you do it properly and you avoid this, your composites will last a lot longer. And basically, what you want is a seamless transition, and this not that. You don't want that. So let's talk a little bit about bonding protocol, because we cannot talk about composites if we don't talk about all of this. There are so many brands of composites out there. They are all very similar. What matters is if you know how to place them, if you understand the composite. So let's talk a little bit about bonding protocols. And the very first aspect of the bonding protocol will be the etching. I learned how to do selective etching long time ago, and it has changed my career entirely. I think I don't get these patients coming back because of, oh, my tooth keep hurting, or postoperative sensitivity, or it just changed. If you understand it, if you utilize, of course, the proper adhesive, you can do selective etching in a way that it does not compromise your bonding. In fact, it makes it stronger. It's actually better for you. When I do selective etching, pretty much what I do is I only etch the enamel. No dentin is etched, as you can see in this case right here. No dentin is etched. I only do etching on the enamel rim around the perforation. Why does selective etching matter? Well, it's the recommended protocol for optimal enamel bond. I don't know if you knew that, but the best way to bond to enamel is this right here, and it also uh provides a more reliable dentin sealing. When you etch the dentin, you're actually killing all those fibers there. And if you don't dry the dentin, if you dry the dentin too much, then all the collagen is gone, and you create an array of exposed dentinal tubules that you don't want to, and you could actually make the bonding weaker if you do total etch technique. I don't want to argue with anyone. I'm telling you with what works for me. I'm telling you what changed my practice, my office, what changed it for the better. And at the beginning, I didn't believe in selective etching because I was starting total etch. And in school, they told me total etch is the only way to go. And that's what I kept on doing for many years. And now when I started doing selective etching, it changed. Everything changed. And the biggest thing about selective etching is that it reduced the postoperative sensitivity by almost 100%. Almost 100%. I don't get those calls anymore on the weekend. My composite is still hurting. I don't get it anymore. And hopefully, next time you see a preparation like this, and you don't do that, because if you do that, hopefully you don't do that. But if you do that, you're gonna get some. You're likely gonna get some postoperative sensitivity. And I stopped doing that a long time ago. Now let's talk about the next thing here. If you want to get good composite, if you want composite to last, the next thing I want to talk about is isolation and preparation. A lot of people are not gonna like probably me saying some of the things I'm gonna say here, but I will say them because I truly believe that the only way to do proper dentistry is with rubber dam. If your dentistry is good another way, if you have moved the needle, like I said, and made your composites last over 7 years, if your composites are lasting 14, 15 years, if you're not getting staining in your margins, if you're not doing any of that, then I guess what I'm saying here is it's not relevant to you. So, but what I can tell you is rubber dam, I think, is the only way to go if you want to have long-term success in your composites restorations. Not here to argue with anyone. This is my professional opinion after reading research about it. Okay. So isolation. There are many methods to do isolation. I know, cotton rolls, who haven't who hasn't done cotton rolls at least one time in their careers, you know? Hopefully you're not the guy doing root canals like this. But cotton rolls is a way to do isolation. There's also cheek retractors. There's many ways you can do isolation, retraction cords, and all this other stuff. There's something called Vidover. I don't even know what that is. I've never used it in my life. I'm sure that it exists, but there's several things. Isolite. I do use Isolite for my crown preparations. It is a great system. In fact, I have used it if you do have if you have like a class 5 really on the back of number 18, something like that. I understand you may not be able to put rubber dam there. I have a fee for service practice. I don't have a bunch of patients at once. So I can take my time on my composites. I used to work in a higher paced office where I needed to get that composite done in 5 minutes, or you didn't make money. You know, you had to a bunch of things that had to do at the same time, 5 chairs going. I understand it. It is a little harder when you have a higher volume type of practice. I've been fortunate enough that I've been able to trans, translate my practice to fee for service, so I can almost take a little bit more time on my composite, having had to use a isolate so much. But rubber dam has been around since the 1800s. 1862 was actually the invention of the rubber dam by Sanford Christie, and he actually gave it to a gift as a gift to the profession in the 1864. So it's been around for over 100 years, almost 200 years now. So rubber dam is not something that is new. It's actually being used for several for hundreds of years now, and I think it's just the best way to do it. And research shows that the use of rubber dam has a great effect on the longevity of composites, and it's just, if you want to do good dentistry, is basically the way to go. There are many ways. I got so hooked into rubber dam that I was even doing my crown preparations with it. Just to prove that you could use rubber dam in certain ways. That if you're in a faster paced office, these are certain techniques that you could probably implement in your office. It's not ideal. You will have some leakage here. You have blood here going on. You got a lot of stuff going on, but it's better than nothing. So some sort of rubber dam will be ideal in your practice. The next thing I want to talk about are the dental adhesive. And as you can see, we started with the etching and with the isolation, and now we're going to drive into the dental adhesive and how to get proper composites in. There are several brands of dental adhesive out there. Yeah, really good brands. I just picked six of the better, I mean, not the better one, but six of the most common ones that I think people use out there. Bone Universal, Scotch Bone. These are probably 90% of dentists or 80% of dentists are probably using a variety of this adhesive in their practice. I will tell you what I use, what works in my hands, and I will tell you why I use it and why it works in my hands. And I've done a lot of research about adhesives. I use Bone Universal. And there are many, many reasons why I use Bone Universal. If you use it one time you use it, you're gonna be hooked into it. It's just, in my opinion, is one of the best adhesives that are out there. At least one of the most convenient ones. It's got 30 years of experience at Bisco. Bisco is the one that makes Bone Universal. It's got one bottle. I understand the concept of two bottles and all that. I understand they could be superior in certain occasions, but I am a very hyperactive person. I cannot have a two-bottle system. That would drive me insane. And the other thing about Bone Universal is that it's got a very low film thickness that everyone seems to be talking about all film thickness nowadays. But think about this. It has less than 10 microns. I remember in dental school, they used to tell me that I shouldn't cure the bonding before cementing the crown or something like that, because adhesive, if I did that, the crown wouldn't cement when I was bonding a crown. That was crazy. You're supposed to cure the adhesive. Bone Universal has less than 10 microns. There's no way that that's going to raise the crown margins. There's no way that's going to separate the crown. It's less than 10 microns. It also contains MDP for those occasions where you want to bond zirconia, a little bit of moisture tolerant. It's a great adhesive to have, and you can use it virtually with any cement. It doesn't matter if it's a dual cure, self cure. However it is, you can use it. It's a very versatile adhesive that I like a lot. a little bit of history about this adhesive. When I got to my practice, when I purchased my practice, there was a certain adhesive here that I'm not gonna say because I'm not here to talk about any adhesives. But I was using that particular adhesive, and the dental assistant I had came with me from a different practice, and she was used to use Bone Universal at that previous practice. When she saw me evaporating the solvent on Bone on the adhesive that was at this practice, and when I got rid of, the first thing that she told me, she's, "Oh my gosh, why is this adhesive so thick?" And that clicked in my head. I was like, wow, even a dental assistant realizes that this big brand is so thick. And immediately I switched back to All Bond Universal because it's what do you call low film thickness. All right, so let's talk about adhesive here real quick. So two things you have to understand about adhesive, and it's going to be the water content and the pH. Why is water content and pH important? Because the lower the pH, the more acidic something is, and the higher the hydrolyzation factor of that something will be to the bonding process. Let me rephrase that in a different way. More pH, more acidity will result in higher failure rate. Something acid will break the bond, right? The next thing you need to understand about water and pH is the higher the water content, the harder it will be for you to evaporate that solvent. So you want something that has low water content. And another thing is, the more water something has, the lower pH that something will be because of the hydrogen ions that are present in water. These are different adhesives right here. All Bond Universal, Scotch Bond, iBond U, OptiBond, different. If you can see here, the blue lines are the water content. The red are the pH value. Out of all of these right here, the only one that has the lowest water content and the highest pH will be All Bond Universal. What does that mean? High pH, that means that it's more basic, good for bonding. Less water content, easier to evaporate, good for bonding compared to a Scotch Bond Universal, compared to OptiBond and all the other ones. So this is a good concept to understand, and one of the reasons why I switched to All Bond Universal and why I argue with people about that. Anyways, so let's talk about composites now. What do I use? I just picked this composite because it's what I use every day. And I picked this one to show you my technique, to show you the things that I do. There are several different composites out there. There are really good brands that have been in for a very long time, and they're really, really good. And depending on what I do, I use different composites. It doesn't mean that I use these all the time. If I am trying to do a really quick fix on something that I know that Omnichroma will do a great job there, I will use Omnichroma because it gives me a nice transition. If I am doing a something that I know is gonna require maybe a little bit of ions release or more calcium and all of this stuff, I may use a little bit of shuffle composite flowable if I am not in a very low bearing area because of their Gyromer technology. And Philtech 3M makes great composite. There's a lot of brands, really good brands out there. I'm just gonna talk about Universal because it will be impossible for me to talk about all the composites that are out there, and also because I am very familiar with Universal, and if I have to answer questions, it will be a lot easier to answer composites to answer questions about quantum composites. So the composite that I'm going to talk about today is called quantum. It is a universal composite. It's a single system, and it's got great filler content, and it's got great viscosity. One of the best things about quantum is it doesn't stick to your instrument. So those days where you had to wet your instrument and the wetting resin to adapt the composite to the margins are gone, because quantum really allows for you to adapt the composite to the margins of your preparation without you having to wet the instrument on the wetting resin. And the next thing about quantum, and I will explain it in the next couple of slides, the reason why is it's got a great polishability. It polishes it really, really nicely. And you'll see some of the examples I've done in the composites. It's very and it also reduces its lumping, and it's great to contour. So it is a true universal system. Universal composite basically means that you can use it in the posterior and you can also use it in the anterior area. What are we looking for in a composite to be used in the posterior? Basically strength, shrinkage, and micro leakage. You don't want to have any micro leakage. You want to have something strong. And what do we look for in the anterior? Basically something that you can polish real nicely. I know we forget about polishing the posterior sometimes. We shouldn't, but we forget about that. And also that does not stain easily, and it's great for shade matching. Quantum is got that little combination thing that allows me to do my dentistry really well. And why do I choose Quantum? Because every time I tell you about a product, I will tell you why I use it. There are some other products, but I want you to understand why I use Quantum. Well, basically, if you remember when we were talking about the fillers, there are different fillers. Quantum basically took the best of both worlds from the microfillers and the nanofillers, unite them together, and it uses a combination of microfillers as well as nanofillers. This, in addition to something that they call aggregate fillers. It's a secret sauce. They call it the secret sauce because I don't know if they want to disclose it or not, but that's what they call it, the secret sauce. And it's basically, it has a combination of multiple things getting the best of all of these words right here. And I took these slides from Dr. Rolando Nunez. He's from Bisco, and he let me borrow these slides right here. So I had to give him credit for these. And basically, what I'm trying to explain is in the next couple of slides, it's how Quantum works and why I use it. And it's one of the things that, one of the topics of this lecture right here. So a microfill composite, think of this green as the BIS-GMA, and think of the black diamonds as the microfield. If you do a slice in this composite, if you cut this composite, this is what you're gonna have at the surface of the composite, something that is gonna be very bumpy. If you take a look at that, when you put this into the microscope, all these areas right here in a microfield composite, this is what you're gonna have. In a nanofield composite, on the other hand, you're gonna have what we call a smoother surface. If you remember these bumps that you had here, you don't have them on the nanofield composite. So what did they do at Bisco? They got the best of those both worlds right there, and they use the nanofillers, they use the microfillers, they use the formula they call the secret sauce, and a low what do you call resin content. Mix all of this together and got something like this, where you can get microfills, nanofills, the aggregate formula, and it's got a great polishability. It's one of the best composites that I've used so far. It works really good in my hands, and I think it's just the way to go. Other things about Quantum, for those of you who are interested, it's got above average compressive strength, flexural strength. For those of you like to know about shrinkage and tensile strength, it's a really good composite. And other things is it's one of the very few composites that are advertised as that you can warm it. You may think that I'm trying to sell Quantum. I'm just telling you why I use it. All right, and why do we care about warming composites? So let's talk about warming composites. Basically, what warming the composite is allowing you to have the composite less viscous, right? So you're allowing that composite to be more flowable per se, without losing the properties, the strength of the composite. So warming a composite, I use it all the time, and I think everyone should be warming composites, to be honest. It helps with the margin adaptation of the cavity walls. It also helps with the shrinkage stress when you're doing, remember the white line. It helps with that, with the white line. It makes it a lot easier to sculpt and to polish, and it reduces micro leakage. So if we want to go back to the 5 to 7 year average that a composite lasts, if you still want to move that needle up and be above that average, you don't want to be below. You don't even want to be at the average. You want to be above the average. warming composite may be one of those things that if you add to your routine may help you have composites that are last a lot longer, and you have better pretty much everything in your composites. And the last thing I want to talk about composites is basically polishing. All resins, any resin, even sealants that you put in somebody. If you use sealants, I don't know if you use sealants or not. Even if you use sealants, you must polish those. Every resin must be polished. I try to keep my armamentarium very reduced, I guess low armamentarium. So I keep my polishing very simple. I use the Jiffy brush. Sometimes I use the ASAP brush, the wheels, the pink and the purple wheels. I really enjoy using the shuffle disc system that you use it in series. You start with the black, purple, green, and then the pink. And sometimes if I'm in like hurry, I just want to do something real quick, I may use the conventional polishers. But I typically keep it in this area right here. This for interiors, this for posteriors, and this for like special occasions. And basically what polishing allows for composites, it's reduces the chances of staining, and it makes it smoother. Of course, makes it smoother, and it just it makes the composites pretty much last a lot longer and look a lot nicer. And just talk about a couple clinical cases. We'll still have maybe another 9-10 minutes, so I can allow you time to talk to for questions. And I'll talk about a couple composites that I've used. I'll also talk about quantum, and I'll talk about how I approach like deep cavities and things like that. Some of the composites that you will see here were from when I used to work at other office where we're a little bit faster paced. I always use rubber dams, but I some of those maybe I didn't have enough time to carve and make them a lot nicer. Some of them a lot nicer, but what I can guarantee you is I always use proper isolation, proper technique, and they hopefully are still going strong in the mouth. So something like this, you open the tooth, big cavity. Gosh, bro, what do we do? Root canal. This was done about 3-4 years ago. It's still going strong. Never was root canal. When you excavate that cavity, I use a little bit of glass ionomer. And yes, I still use glass ionomer occasionally. And the reason why is because if the cavities are not in the nerve, in the pulp, glass ionomer is a great product to have. It releases fluoride, it calms the nerve. It's a good product to have. So I use it occasionally. And you can use it like what we call the sandwich technique, where we use a little bit of a base of glass ionomer and put the composite over it. It's been over 3-4 years. The tooth is still going strong. Nothing going on with the tooth. And finally, after you do anatomy and all polishability on the tooth and all that, and that's how it looks. Why use glass ionomer? I don't use it all the time, but it's a good product. It's a good thing to have that we're kind of forgetting about. We don't even use them too much anymore, but it's something that you could probably consider in those class 1 preparations at the base of the preparation. It helps with many things. And quantum per se, all right, if we have something like this, we got a couple class 2s here. The first thing I do in all my preparations, I put a rubber dam on, open those preparations, try to be a little bit minimally invasive there. Once preparations are opened, I like using the Garrison system. Yeah, I think it gives me better contacts. It is a great system to have. Tough-Myers are okay, but I think Garrison gives you better retention. I've used some other knockoff brands, if you want to call, and I don't think it gives you the same effect as Garrison. Garrison, I think, is the way to go. Selective etch. I always do selective etch. Scrub the bonding in for 10 to 15 seconds. So make sure if you're doing selective etch, you must scrub that bonding into the cavity walls and the floor and the dentin for 10 to 15 seconds, because if not, it doesn't work. And you're supposed to apply at least 2 coats of adhesive if you're using All Bond Universal. Then build the marginal ridge. I use a splitter to kind of guide the resin to where I want it to go. Once I have the marginal ridge laid down, I cure for 20 seconds. Make sure that you have a pulsing curation on that light, like curing light. Once I do that, I start building the anatomy in an anatomic way. If you remember the triangles we were doing, that's basically what I started doing here. And once you get all the anatomy going, and a really good technique that I learned some time ago was to use the shuffle disc to carve the excess composite that is around here. That works really, really nice. You can use a single-sided disc on those areas, and it allows you to get that marginal ridge really well adapted to the preparation. This was not a great composite, maybe mainly there are better ones. It just was a quick one. They asked me that I was working on. I said, let me just take some pictures. Of course, it's not the best one. I had some other pictures to go and all that, but what I can guarantee you is this one's gonna last. There are no white lines in the areas that I touch. There's nothing there. So this is something that is gonna last you. Another composite is here over here. Kind of like a deep preparation. We put a liner of Dicol. I didn't use glass armor this time because it wasn't a little bit bigger. I used something called Therocol LC. Really nice, like your calcium releasing product where you can put it for indirect and direct pull caps. Once I get that done, anatomic building of the tooth. And this one, I used a different strategy. I left the marginal ridge for last, and it's because the way I was working on these tools, I was a little bit uncomfortable to build a marginal ridge first. And if you notice on this one, I did use a Meyer because I can't remember why I used a garrison. I think I couldn't place a garrison on this particular case because of the position. Anyways, I finished it. Of course, the tooth is not hydrated. I didn't use tints. I didn't use pigments. I didn't use any of that on this one. But the tooth is dehydrated. Once the tooth hydrates, it's gonna get the color. Another clinical case here, and this was on with Quantum, class 1 preparation. Remember, it's got the highest C factor, highest shrinkage stress. Another case that I did here that I probably I took my time a little more on this one for a class 1 preparation on 18 and 19. Both were done with I think I might have used Quantum. Yeah, I used Quantum on this one as well. And if you want to do some anterior restorations, I actually published this article on dental products recently, and I'm not gonna give you all the steps because I don't think I have enough time. So I might skip here. Let me see. Let me skip a couple steps here. Etch on this one because it's all enamel. Once you finish polishing, you get the front teeth polished there, and sometimes you want to be really Therocol LC. Same if you get those preparations. I know my isolation probably was not the greatest here for those who are really picky and all that in this area, maybe here, but I did actually end up placing a Teflon tape in that area at the end. So sometimes I use tints, sometimes I don't, depending how the day goes and how much I want to spend on polishing and all that. Yeah, sometimes I get better composites, sometimes it depends how much time or effort I want to put into the composites. But the main goal is take your time, don't rush the composites because they will fail unless you want to be in the patient in 5 years. I don't know. That depends on you. Other areas, this is not polished, it's just right before polishing right here. Let me see how much time I have. 3 minutes left. So let's run through this one real quick. Kind of the same concept. First layer of a liner of flowable composite always building layers. And if you notice how I build these layers, I start with opposite sides. Reason why is that allows for the polymerization shrinkage it gives some time to this one while this one is recovering, I guess, for lack of a better word. But yeah, I always start on opposite sides of the preparation when I'm doing my anatomic building. And then I jump to the side over here. I use pretty much very few instruments. I use a spatula and exploder to carve the center. And as you can see, I finish here. And I mean, it might not be the prettiest compositor in the world, but I think it does the job. Hard to notice. And I'm very happy with the result right here. Other uses you can do for class 5. When I do lectures on live lectures, people ask me, how do you place the rubber dam on a class 5? Well, sometimes I don't technically, but I do this, which is a slit preparation we were talking about. So if you do a slit preparation, it might not be ideal because you still have circular fluid there that is contaminating your preparations and all that. But in this particular case, I was kind of rushing, so I had to do something. So basically what I want you to take from this lecture is sometimes it's not feasible to do a rubber dam all the way, but even if you do just a little bit, it will help you. It will increase your chances of um of what do you call success on those preparation and move the needle, as I was telling you, to a um longer lasting results. Other uses for composites is I use it for temporaries as well. Some of the things that I use with composites all the time is when I'm temporizing implants, I place implants, anterior implants myself. I actually publish these articles as well in a different journal. Is I use nanofills composites for temporaries. I just make a little blob of composite, put it over the tooth. I don't have enough time to explain because this is a different type of lecture for implants. But as a ribbon fiber down here and back here, and I create something like this was a little preparation. Put the ribbon fiber like so, even leaving two wings like that. And those two wings are the ones that I attach to the adjacent teeth. And then this is a different type of lecture where I show how to bond to zirconia. This is a zirconia crown. This is an actual tooth. And I actually show how to bond a temporary to a zirconia restoration. You can actually bond to zirconia. You can actually read more about that if you use Z prime. Anyways, and another uses of composites that I use is for contouring the emergence profile of implants. This is what's made. This was done with Quantum. As you can see, how it's very, very, very glass finish on this one, and it allows for obtaining something like this, like that, after the implant has been placed in the area. And this is the same implant that you saw before. If you're interested about Quantum, this is how you can order some of the dents, the H 10,000K and the H 10,100K. These are the ordering information. But again, this is not the only composite that is out there. You can technically use many of the other composites. If you have anything else that works in your hands, great, and you get good results, use whatever you're comfortable with. Just make sure you do the research. Every time I use a new product, I don't use it because a rep comes to my office and tells me, "Oh, use this because so and so." So I actually do the research myself and have a reason. Always have a reason as to why you use what you use. It being a composite, adhesive, etch, whatever it is. Even etch is important. If you have benzalconium, if you don't have benzalconium chloride in your etch, you should be doing Conceptus chlorhexidine on your dentin, things like that. So always research what you do, what you use, and I'm gonna leave my contact information here below. That's my email address, and I also leave a couple of my Instagrams. We're trying to build the OTM dentistry page here. That's my new practice. Um, I'm not the greatest at social media, so it's taking some time to build the practice. So I appreciate if you guys give me a follow there. You know how hard it is nowadays to build social media and all that. If you're in the business, it will help me a lot if you follow there because that's a pretty much the backbone of a practice now, social media. Anyways, I'll allow this the next 8 minutes we have here for questions. If you have any questions, hopefully I can answer your questions. Hopefully you learned something here today that you can take home and apply tomorrow.
Hey, doctor, click the Q&A button.
Yeah, I'm in the chat box here, but yeah.
Oh, not the chat, the
Yeah,
Q&A.
yeah, I got it right here. Let's see. Have you heard of self-curing bulk fill Stella? I've heard of it. I haven't used it. Here's the thing about bulk fill. When people talk about bulk fill, they automatically think you can fill the cavity preparation all the way to the top, and that's not why bulk fills are made. The concept behind bulk fill is that you can technically cure up to 4 millimeters of your composite. 4 millimeters is not a lot. So you still have to layer your composite. You still have to follow proper protocols and use I use bulk fill all the time. I use GC bulk fill from GC and it's great. It works great. No, I haven't used the Stella one, but But the thing about bulk fill, if you use it because you want to be speedy and fill all the way to the top and like you're just not gonna you might as well use any other composite because that's not why bulk fills are made for. Here we go. I do total edge and apply dentin desensitizer. You're reducing bonding strength right there. So there's a question here that says, I do total edge and apply dentin desensitizer. I rarely get post-op sensitivity, which is with selective edge. Would you still recommend dentin desensitizer? I don't use any dentin desensitizer. No, I don't use any. I haven't used a sensitizer in a while. Maybe even cementing a crown, something, but dentin desensitizer, you have to be careful because of the HEMA and because of the things that they contain. They can actually weaken in your bond. So you have to make sure you use a desensitizer that is proper for that. There's actually, I don't want to argue about that, but there's actually research that indicates that the sensitizer does weaken in the bond strength, especially the dentin. Yeah. So the best way to do is selective etching and just apply what do you call bond right after it. Um, let me see if I can do the question here. How do you get a rubber dam on 16, then a DO composite on 15 without the clamp getting in the way? Well, you're gonna have to take it. That's a good one. If you have a really thick cheeks and all getting on the way. Here's the thing about rubber dam. I struggle with it so much until I learn how to use them. So once you learn how to use them, you kind of feel naked without it. It's the best way that I can tell you. Like I floss my teeth right before I go to bed every day. And if I don't do it, I feel like something's missing. Well, when I'm doing a cavity preparation without a rubber dam, I feel like something's missing. Like I tell you what, my assistant is almost as good as I am putting rubber dams in. Like I numb the patient, and sometimes when I get in there, that rubber dam is perfectly placed. I don't even. I place maybe half of my rubber dams. The other half my assistant places them because I just get them numb, just do something else while I'm doing something else, checking hygiene. The rubber dam is placed. I don't even deal with it. But I think the best way is just I guess to take a course in rubber dam and all that. But it's rubber dam is the way to go. This you can put rubber dam in many areas. Um, how long of time are you like curing what you're building up in layers? You're supposed to cure about 20 seconds, and the last layer is supposed to be 40 seconds. I know it takes a long time, but that's how much you're supposed to be curing the composites. 20, and then at the end 40 seconds. Where could we find that lecture on temporizing implants with the composite? Oh yeah, that lecture. It's just a lecture. It's a whole It's actually a 4-hour lecture that I do on the temporizing implants, placing it. I do a lecture that's all the way from the start, placing implant all the way to the end, temporization. But it's a 4-hour lecture, and the only thing I did was I grabbed 4 images from there and I put them there to show what else I could do with composites. I'm sorry, this is more like a basic lecture about composites. Yeah. Um, is Quantum available as a flowable and packable? Also, you fill a tooth in incremental triangle fashion. Can you bulk fill as well? Yeah, you can bulk fill if you do triangle. In fact, you're supposed to do the same technique. If you use flowable composite to bulk fill cavity preparation, you're supposed to be doing it the same way in a triangular fashion where you avoid the bonded surfaces to the cavity walls as much as possible. So the goal of bulk fill composites is always they're not made to replace the technique, but rather to make it more simple in terms of curing. Think about a bulk fill composite as the same as a regular composite that you can cure in 4 millimeter increments, but that doesn't mean you can use more cavity walls or you can put any more of that. I mean, even if they advertise it that way, because they could advertise it that way, you're not supposed to. The less number of bonded walls you have, the lower the C factor, the less you're gonna have for breaking a composite. And Quantum doesn't have flowable just yet. Quantum is a very new formula. It's a very new composite. It's got one of the newest in the market. They recently came out with the packable, and they're working on the flowable. hopefully, we had a lecture 2 days ago. I'm one of the key opinion leaders for BISCO, and I had a lecture the other day that they say that they're working on the flow, but they're working on some other stuff as well. Also, I'm a fellow Birmingham dentist. Oh, hey Kelly, nice seeing you here. Um, Which flowable composite do you recommend? I use Shuffle composite because it has a gyromer technology. It has 5 different ions that helps remineralize the tooth and it helps with sensitivity. And it also have some properties similar to Omnichroma, the Shuffle composite. Um, the thing about Shuffle composite, you have to be very careful with the way you place it on the tooth because it C factor is definitely an issue there. And then the other composite that I use very often is the GC bulk fill. They only make it in 2 shades though. They only make it A1 and A2, I think. But if I want to do bulk fill, I use GC from composite. And if I want to use something else, I might use like maybe like an Omnichroma flow or maybe a shuffle composite. Shuffle is the way to go because of the gyromer technology they have. Research gyromer, GIOMER. Is a really good concept they have. Hey, thank you for those who are saying thank you for the lecture. If you do see a line after completing a composite, how do you usually go about fixing it? Do you drill out the line? Well, I don't know how to answer that question without yeah, I mean, if the patient's already in the chair, you see a line, yeah, go back at least try to fix it because you know that's gonna fail. If you cannot replace entire composite because of timing, I understand it. Um, just re just drill that little line again and try to make it in layers at least to see if that area doesn't happen again. I would recommend everyone to buy a camera. That's the best way to go for to learn from your mistakes. For how much seconds and etching? Oh, I'm guessing the question is how many seconds for the etchers to be placed. Etching 10 to 15 seconds for enamel, 20 to 25. If you want to do dentin, over 20 seconds, 20 to 30 seconds for dentin. But I would only etch dentin on my mother-in-law. Just kidding, just kidding. I'm just messing there. But yeah, I don't etch dentin because of the sensitivity. Um, let's see. What is your process for layering SCL? Fine. I don't understand that question. I'm sorry. What is the process for layering SCL? Oh, a class two finding MOD. I'm sorry, I couldn't understand the last question there. And I think I might have answered all the questions. If there's anything else that I can answer, let me know. Thank you guys for being here.